The topic of our presentation today is about physiotherapy for autoimmune and rheumatological conditions. The brief overview of today's presentation. Firstly, we will talk about the aim of physiotherapy. Next, we will look into the common conditions seen by physiotherapists in autoimmune and rheumatology clinic, followed by physiotherapy management and indications of physiotherapy referrals. The aim of physiotherapy is to optimize patients' ability through exercises, to educate proper biomechanics and work posture, to prescribe walking aids and assistive device as required to improve patients' independence and quality of life, and last but not least, to empower patients in self-efficacious long-term management. We get to see patients with different types of conditions in physio clinic. This includes rheumatoid arthritis and osteoarthritis, scleroderma, lupus, spondyloarthropathy, gout, etc. In this presentation, we shall focus in three commonly seen conditions, which are rheumatoid arthritis, spondyloarthropathy, and scleroderma. I will talk about the clinical presentations and physical impairment that physiotherapists will assess before planning their intervention. Rheumatoid arthritis. RA is a progressive disease that leads to significant pain, joint destruction, and functional decline in patients. It affects multiple tissues and organs in the body, in particular synovial joints and periarticular tissues. The main clinical features of rheumatoid arthritis include tender, warm, and swollen joints, complaints of joint pain with loading and movement, joint stiffness in the morning and after a period of inactivity, joint deformity which often seen in patients' metacarpal phalangeal joints, proximal interphalangeal joints, wrist joints, toes, and knees, cervical myelopathy or neurological abnormalities in patients with cervical spine involvement, not to forget about fatigue, which is a very common experience for people with RA. Spondyloarthropathies. Spondyloarthropathies is a group of common inflammatory rheumatic disorders, which includes ankylosing spondylitis, reactive arthritis, psoriatic arthritis, and juvenile onset spondyloarthritis. Common clinical presentations and physical impairments seen in AS patients include joint pain with loading and movement, especially at sacroiliac joints and spinal joints, joint hypomobility or reduced in range of motion. This can be observed at spinal joints, hip joints, and some patients may present with knee flexion contracture. Pain and difficulty in breathing due to inflammations or in later stage, fusions of their costal vertebra and costal transverse joints, which limit their chest wall range of motion. AS patients may also complain of fatigue due to inflammation occurs in their body. Scleroderma. Scleroderma is a systemic disorder which affects the connective tissues of skin, internal organs, and walls of blood vessels. Besides stiff and painful joints, especially on their hands, scleroderma patients also suffer from dry skin and tightness which lead to contracture. They may present with swelling of fingers and toes, pitting, ulcers, or loss of bulk from finger pads. Other clinical presentations include breathing difficulties and reduce in exercise tolerance, peripheral neuropathy due to reduction in nerve conduction velocity. This flowchart summarizes the usual workflow for physiotherapy. We start on with patient's assessment, followed by treatment, reassessment, and to promote self-management among patients. We will provide patient-centered home exercise program and practice strategies such as setting goals with patients, get patients to better understand their disease, and identifying their needs. Treatment approach is different for each individual, even if the diagnosis or injury is the same. Majority of the patients seen in autoimmune and rheumatology clinic have chronic musculoskeletal pain. A multidimensional profile is commonly used to address patients' physical, lifestyle, and psychosocial factors, which in turn guide the clinician to plan a holistic management. Physiotherapy treatment begins with an understanding and identification of patients' goals. Clinician will discuss with patient during initial assessment about their expectations of physiotherapy and to set realistic short and long-term functional goals. We educate patient about what to expect in their disease to ensure they have a better understanding of their symptoms and learn how to manage them. Different modalities that we administered are therapeutic exercise and other electrophysical modalities. We also perform manual therapy and soft tissue release depends on patient's clinical presentations. It's important to explain to patient regarding the role of physiotherapy and what to expect in the short and long term. Patient develop knowledge of their illness and understand that using their joints does not equal to damaging their joints. Besides discussing patient symptoms pattern, it's essential to identify the optimal periods for physiotherapy, which is usually after morning stiffness subsides or after their medication. We also emphasize in pacing by helping patients splitting tasks into small bits, not overdoing or underdoing stuff. Patient education is proved to be having a good short-term effect in patients' disability, psychological status, and depression. Therapeutic exercises are commonly prescribed during physiotherapy session, as patients may have difficulty coping with pain, fatigue, and joint stiffness. Our exercises prescription will need to accommodate patient's symptoms by identifying the optimal timing for exercises, the appropriate level of physical activities, and monitor the fluctuation of patient symptoms during intervention. The FITT guideline is a good way to guide patients' exercise program. We will modify the frequency, intensity, time or durations of exercises, and type of exercise to better help patients in achieving their functional goals. Exercises are prescribed with the aim of improving patients' flexibility, strength, proprioception, motor control, agility, and power. There are evidence that support exercise among RA patients. Resistant exercise improve isokinetic, isometric, and grip strength significantly in RA patients. A combination of aerobic and strengthening exercise is recommended for patients with RA. Aerobic exercise serves as a good adjunct to help with pain and to improve functional impairment. It is also effective at reducing fatigue in short and medium term in RA patients. Submaximal exercise, such as cycling, helps to reduce pain, improve cardiovascular fitness and strength. Supervised exercise and gym-based exercise help to improve function, quality of life, and strength in early RA patients. Next, we move on to different types of exercises. These pictures demonstrated some of the upper limb strengthening exercise which target at rotator cuff muscles, periscapular muscles, and arm muscles such as deltoid, biceps, and triceps. Lower limb strengthening such as straight leg raise, bridging, and wall slides target at quads muscles, gluteus maximus, and gluteus medius. Different upper limb stretching such as pectoralis muscle stretch, shoulder posterior capsule stretch, hand behind back stretch with towel, and pulley to assist with shoulder range of motions. Patients with lower limbs muscle tightness may benefit from quadricep stretch, calf stretch, and hamstring stretch. Some of the commonly used back stretches that are useful for ankylosing spondylitis patients, such as lumbar rotation stretch, prayer stretch, thoracic rotation, and seated lumbar flexion stretch. Gym equipment such as stationary bike, cross-trainer or elliptical machine, arm ergometer, and treadmill can be used as a form of cardiovascular fitness training. Cardiovascular response such as unexpected dyspnea, chest pain need to be monitored carefully during exercises. Functional rehabilitation helps to improve functional status of deconditioned patients or patients with post-surgical pain. It's also aimed to facilitate patients' return to work or sports and to reduce the risk of recurrence. Next, we move on to manual therapy. Manual therapy includes joint accessory glides on the spinal joints or peripheral joints with the aim of reducing pain and improving joint motions at segmental level. We also perform soft tissue release in order to reduce pain and to improve patients' flexibility. Electrophysical modalities is another component of physiotherapy treatment technique. Some of the commonly seen modalities include TENS, heat treatment, interferential therapy, and ultrasound. Electromodalities help to relieve pain, promote muscles relaxation, and increase blood circulation, which can be helpful for patients with inflammation. However, there are some precautions and contraindications that we need to consider while managing patients with autoimmune and rheumatology conditions. For rheumatoid arthritis patients, high irritability due to active inflammation may limit physical examination and treatment. High-intensity exercises should be avoided during an acute flare-up. High-grade joint manipulations are contraindicated in rheumatoid arthritis patients as chronic synovial inflammation, bone erosion, osteoporosis, and cartilage destructions may lead to joint instability. Same goes to ankylosing spondylitis patients. High irritability may limit physiotherapy assessment and treatment, and high-grade joint manipulations are also contraindicated due to the risk of fracture. At the last part of today's presentation, we will talk about the indication for physiotherapy referral. Physiotherapy attend to patients who present with loss of physical functions, patient who is lacking of knowledge regarding exercises and physical activities, patients with newly diagnosed inflammatory arthritis, patients who require pain management, to restore joint range of motion and improve muscle strength, patient with moderate to high fall or fracture risk, and also patient with moderate to high cardiovascular risk. Here comes to the end of my presentations. Thank you for your attention.